I'm excited to be here. I love to talk about medications. I'm a geriatric specialist pharmacist, which means I sought out a lot of additional education in geriatric-specific medication information. And I'm also a pharmacist, primarily a consultant pharmacist in long-term care. Like I said, there's so much time or so little time and so much to say that it's like a treetops overview. We're just going to do a broad stroke view, identifying common medication issues and side effects, those kind of things. It's more of a be aware situation today. I don't want to scare you in any way, but we're going to mention a lot of side effects and things that can happen. But let us know if there's anything in depth that you would like us to go through later on, additional presentations that you may like to see in this area. And I think it's pretty common sense to ask the question, why are meds in the elderly a concern? Older adults typically take more prescriptions than other age groups, and that's been shown by studies, but it's also common sense. I think we're all pretty aware of that. Older adults are at increased risk for serious adverse drug reactions, and age-related changes in your body, I think we tend to think, oh, you know, adult is adult, but changes happen when you're elderly or when you're getting to the stage of becoming elderly in the way you absorb drugs, how they're distributed in your body, in the metabolism, how you break them down, how you use them, and how you get rid of them. Polypharmacy is just a great big word for use of multiple medications. We're going to talk about that, and as you might think, common sense-wise, when you have lots of medications and you're taking a lot of things at once, you can have drug-to-drug interactions where they interact with each other, and you can have drug-to-disease interactions where particular drugs interact with you and your disease state in a different way than maybe we'd like them to. We're going to talk about potentially inappropriate prescribing, specifically the Beers List medications, and potentially inappropriate monitoring of drug therapy. Some stats to just kind of get us in the mood to think about why this is such a big deal. 75% of older adults take at least one or more prescription drugs. You'll see some abbreviations on the slide. That RX is just a common prescription abbreviation. And 25% of older adults take 5 or more medications on a regular basis, and more so women than men, but still men. On average, patients, I love this, on average, patients 65 and older with 2 or more chronic conditions, so let's say you had diabetes and hypertension, those are pretty common, see 7 different physicians per year, and each of those physicians could be prescribing medications, and each of those physicians may not be aware of other medications that you are taking. Warfarin, which is a blood thinning medication, insulin, which is a hormone that we inject for blood sugar control, and Digoxin, which is a medication for heart rate control. These are sort of high alert medications because they're known to have issues. Together, these 3 drugs account for over 1/3 of emergency department visits for adverse drug events among older adults. So of all the drug events that people go to the hospital for, these 3 drugs, over 33% of the issues are associated with them. I want to point out that often, drug reactions are written off as normal aging, and I think that's such a mistake. Slower gait, dizziness, incontinence when you're losing your bladder control, memory issues, yeah, these may be associated with aging in some people, but the 65-year-old sitting next to you in church and the 65-year-old in the nursing home and the 65-year-old that lives on your street are not all the same. Everybody is very distinctly different and is going through different changes at these times. We may have side effects from medications that are causing things that look like normal aging. And then, you know what, we may prescribe a medication to fix that side effect. That happens a lot. It goes on and on and on, and so you have tons of medications, and that's called a prescribing cascade, where we're trying to fix what one medication caused on and on and on. So just a little respect and common sense that I think we should use. I'm going to say you a lot because I want to make sure that we're aware that it's not just the older adult, although that's what we're focusing on, but everybody. You know, don't you want to be on the lowest possible effective dose of your medications? I know I do. It makes common sense that as the higher dose goes, you get more side effects in most medication, and that's true. Do you think it's a good idea to take a sleeping pill every single night? Are you your best the next day when you're doing stuff like that? And for most people, the answer is no. Does anyone want to be drugged into oblivion just to make other people's lives easier? If you've heard me talk before, you know that I tend to do this to my husband with NyQuil when he has a cold. That's not a very nice thing to do, so we don't want to be doing that to everyone. Let's go through just real quick what we're going to go through. So you know, some of this stuff we're going to hit kind of fast, and I'm happy to go through it in detail either on a different presentation or help you with slides or those kind of things later. We're going to go through the Beers list, not the entire Beers list, but basically what it is. And that's just a list of medications that may not be so good for people that are older adults. We're going to go through herbal medications and supplements, samples, and actually I'm going to hit samples right now. Samples are the ones that your doctors give you for free, and maybe it's usually a newer drug, and they want to see before you spend a lot of money on it if it's going to work for you. The problem with that is that it's not in your pharmacy database, so we don't know that you're taking it. Your doctor may not know what all else you're taking, and side effects and interactions can definitely occur. Also, these tend not to be labeled by the doctor, even though they're supposed to be. They're supposed to have about the same information that a prescription label has. So if we find you laying in your apartment, and we find all your medications, and we find this one, it doesn't have your name on it, we don't know how you're taking it, we don't know why you're taking it, and that can be a problem. Tylenol overdose, which acetaminophen, really the active ingredient overdose, is a big issue in the community at large and in the older adults. We're going to go through psychotropics, which is a big word for medications that can affect your mind and the side effects that they have. We're going to go through blood pressure med, common side effects. We're going to go through when you have a lot of meds, a lot of doctors, a lot of interactions, and a lot of medication conflicts, and what we can do about that. First of all, the Beers list. Dr. Mark Beers, who unfortunately died just this past year, wonderful, wonderful doctor who was one of the first people to really look at consensus criteria. So basically he talked to a bunch of experts that were doctors, some were pharmacists, about what medications might not be so great for elderly people. It started off in 1991, it was revised in 97, and then again in 2003. And basically all this is it's a risk-benefit ratio. It's not a, hey, no, don't give this to older people. It's a, hey, there's a lot of side effects. Is it going to work well enough to warrant going through these side effects situation? So the Beers list was really for long-term care, so your nursing homes, those kind of things originally, but now we're using it in hospitals, outpatient, managed care, and other settings. Canada has its own version of the Beers list, which is also very, very good. And it's not called the Beers list, but it's very similar. There's a link, if you can see at the top of that slide, where you can get to the most recent incarnation of the Beers list, if you'd like to. Now, just so you know, some meds are of concern in all elderly people. We're worried about that. Some are just in certain situations, like if you had a really high dose, or you took it for a very long time, or you took it in combination with another medication that wasn't such a good idea. And some, as I mentioned, are a problem with disease states. So, for example, if you're taking Wellbutrin, which is a med that we either use for depression or for maybe smoking cessation, or you're taking Tramadol, which is for pain, and you have a seizure disorder or a history of seizures in the past, these two medications, independently, not even necessarily in combination, can lower the threshold whereby you would have a seizure. So if you're already predisposed to have a seizure, this may make it worse, either of these drugs. Benadryl, which I'm going to say Benadryl a lot because people know that name, really the active ingredient, diphenhydramine. When you're taking that for sleep and you're a dementia patient or you're maybe having some memory issues, this is going to make it worse because of the systems it hits in the body. And we'll go through that in great detail, really. So age-related changes, as I mentioned, can affect how you absorb medications when you get older. Usually you'll absorb everything, it's just going to take longer. So if you were taking a medication for anxiety, say, and you're expecting, or your caregiver is expecting, okay, 15 to 30 minutes, that should be hitting you, and then maybe they want to dose you again if it's not, it's actually going to take a little longer in many older adults, and that has to do for several physiological reasons. Patches, if you're a female who's maybe 100 pounds or less and you're an older adult, because of the way fat is distributed and how little fat you may have at that body size, you're not going to absorb medications from a patch as well as you should, and that's something to consider. Drug metabolism, how we chop stuff up, your liver gets less blood flow as you get older. So the way you're using the meds in your body may be a little different than is expected from the studies. How it's distributed in your body, because you have usually less muscle and a little bit more fat, can be a problem. And if you have any kind of kidney issues, how you get rid of those medications from your body is an issue. And sometimes you could have perfectly normal kidneys, but you're taking other medications, and that's going to affect how stuff gets out of your body. And again, on and on, polypharmacy. Taking a lot of meds is an issue. So the risk-benefit ratio. Side effects of particular concern relate to changes in how medications can make you think, and we'll go through that a little bit with Parkinson's later. How they can affect your balance and coordination. They can change your eyesight. We don't always think about that. They can help you feel dizzy and fatigued, even though we don't want them to. They can make you faint or have your blood pressure drop so that you may fall. All of those things can increase the risk of falls. And then overall, in elderly, and I think this is so interesting, the people who use these Beers medications have a similar risk of falling whether or not they take them just once in a while or whether they take them every day, which I think is really very significant before we think about taking these medications. In fact, there was a 2005 study in the Archives of Internal Medicine that found residents who had an intermittent, so just a once in a while use of these Beers-less medications were at greater odds of dying compared to people with no Beers list medications. I mean, that's significant. And if you're a stats person, just because I thought that was a shocking thing to say, I put the stats down there, the odds ratio and the significance factor there, and that is significant if you're a stats person down at the bottom in parentheses, just so you know. Adverse effects can be nonspecific, like I mentioned, and we write them off as aging all the time. I hear people say it all the time in long-term care, and we just shouldn't. Really, because maybe it is a product of aging, but you know what, we may be making it worse with some of these medications. Specifically, anticholinergic adverse effects. And anticholinergic is a giant word that refers to a certain system in your body and how it affects, but basically, let's break it down like this. Anticholinergic side effects is how most people feel when they take Benadryl. So think about anytime you've taken cold medicine, maybe even NyQuil, which has a sister drug of Benadryl in it, or Benadryl, and you get that dry mouth, dry eyes, maybe even blurry vision. Your thinking is not as clear. I can attest to that from test taking in school after taking cold medicine or Benadryl. Unclear thinking is a big deal with that. Slow moving, urinary retention, meaning that your bladder maybe is not emptying as much, and as we know, if you don't empty your bladder a lot, bacteria builds up and you can get what's known as a UTI or a urinary infection. And constipation, which is a big concern in the elderly. I put slow moving on there twice. I'm not sure why. I shrunk that list up just so you can keep that in your head, because I want to talk for a minute about over-the-counter, those OTC sleep aids. They're almost 100% available with the active ingredient of Benadryl, which is diphenhydramine, or other sister antihistamines such as doxylamine. They are, and I put this in caps, not recommended for sleep in the elderly. They're just not. Neither are those herbal ones, like valerian or kava kava. Those things typically aren't good. They have all these same side effects. It doesn't matter that they're herbal. They're affecting the same systems. So same side effects. And they have been linked to liver failure. And for a while, actually, kava kava wasn't available over the counter. Now it's back. So be careful with that. Beers list, as I mentioned, you can prescribe drugs if you're a doctor that are on the Beers list. Doctors take into consideration people's specific situations, and that's important. But we also have to realize that the drugs need to be revisited in each person, and we need to really examine whether the risk-benefit ratio is appropriate. So remember that even though it's written by doctors, doctors know about it, there's even software that helps us learn about it, it's an ongoing issue and an ongoing area of concern. And I just want to give you a hard example. We may have all heard about Darvocet. It's a pain medication. There's also Darvon, which is a version of it. Darvocet, it's usually a big It's usually a big pink pill, and I hear that the pink version of it works better than the white version of it from my patients all the time. I don't know that that's true, but that's what they believe. It has an active ingredient in it called propoxyphene, and it's not a very good medicine. It's a narcotic, but it's not excellent. Darvocet itself actually is propoxyphene and Tylenol, so just to give you a hard example. So they've led to overdoses, both Darvocet and Darvon, and they're thought to be overall more addictive than they are pain relieving. So, and studies show that pain relief is only equal to that of just Tylenol. So Darvocet has Tylenol and propoxyphene in it. It may be just because of the Tylenol that it's working as little as it works. It's important to realize, though, that the side effects are the same because structurally it is a narcotic. So you'll get your constipation, you'll get confusion, you'll get sedation, and it still has those addictive properties. The FDA has done tons of reviews of efficacy on this, but one of the more recent ones on their website, there's a quote from it that says, there's evidence that propoxyphene, so that Darvon, possesses weak analgesic effects, so just not very good pain reliever, in patients with acute pain compared to placebo. So compared to nothing, it's not that much better, basically is what that means. And there's probably better choices. This is just a quick slide to let you know that Tylenol is an over-the-counter medication for pain and fever. The active ingredient is acetaminophen. I'm going to go back and forth between saying Tylenol and acetaminophen. And acetaminophen is so long, and I didn't want to take up a lot of slide space, so I abbreviated it to AP. AP, that's just sort of an abbreviation for you. That means acetaminophen. So when you see that, you'll know. Combination products, such as Darvocet N100, Tylenol with codeine, various forms of Vicodin, are, to some degree, we're worried about the narcotic component of those, but really the Tylenol component can lead to overdose. There's so much that Darvocet N100 has 650 milligrams of Tylenol per tablet. Vicodin ES has 750 milligrams per tablet. That's a lot, because a typical prescription would read something like Darvocet N100, take 2 tablets by mouth every 4 to 6 hours if needed for pain. So they're saying you could take it maybe 6 times a day, maybe 4 times a day, but greater than 3 doses, you are above the risk for liver toxicity and death. So that is, to me, very meaningful. This is just a little breakdown of, right now, you shouldn't take more than 4,000 milligrams of acetaminophen in 24 hours, which is the same thing as 4 grams, which is roughly equal to your normal strength, about 12 tablets in a day. So if you're taking combination products, you can see how this may build up. There's actually, in the last 2 years, been a lot of movement to lower the maximum dose. And the FDA has gone around and around. You can look on their website and find out about that. The toxic dose may be lower in some cases because it's not only about dose. If you have liver issues, that's a problem. If you're taking alcohol, that's going to maybe lower your threshold. If you're taking other medications, that may lower your threshold. And it really has to do with pathways. I'm not going to get too into the pharmacology for you, but if everything's going along fine, you're in this one pathway. All of a sudden, you start to have issues. This gets overwhelmed. You start metabolizing it in this pathway. Sounds great. Sounds like we're taking care of it. The second pathway produces toxic metabolites that cause liver failure and death. There's no telling in each individual person when you switch over. So that's why we have to be really careful. And a lot of people sort of, oh, it's Tylenol, it's okay. But just so you know, Hepatology, which is a medical journal, did a study showing that 50% of acute liver failure cases, and liver failure is no joke, that leads to death very often, were related to Tylenol or acetaminophen poisoning. The FDA has a recent statement on their website that says the association between acetaminophen and liver injury is not common knowledge. Consumers are not sufficiently aware that acetaminophen can cause serious liver injury, and their perceptions may be influenced by the marketing of the products. So that's a big deal. Side effects of blood pressure meds. Well, if you take blood pressure meds, you might be aware of this, or you take care of someone who takes blood pressure meds, you might be aware of this, but they're common meds. So I wanted to say that they can be sedating. They can affect your heart rate. So even if you're exercising, your heart rate's not going up. And that's intentional. They're meant to do that, but it can be a surprising side effect. They can cause depression, in particular the ones I have listed here, metoprolol, carvedilol, labetalol, clonidine. They can cause dizziness. All of them can cause confusion to some degree. And I have the meds listed here, but really just to know that a lot of blood pressure meds can cause these is the point. They can change your electrolytes. They can increase or decrease your potassium or sodium. We all know even from watching TV that can cause heart failure and heart attacks. That can be a problem. Hydrochlorothiazide, lisinopril, spironolactone, Lasix are some I could think of. I was recently in a bathroom in a mall in Tucson, Arizona, and a woman about 3 stalls down passed out. Her daughter started screaming bloody murder. Someone help. My mom passed out. Someone help. I went over. Woman, was awake pretty quick, came back, was able to be oriented pretty quick, and interviewing her, I found out she had recently started this water pill, hydrochlorothiazide. It's hot in Tucson. She hadn't adjusted her water. I don't know that her potassium was where it was supposed to be. I didn't have lab results. We had to call EMS for her. There's several physiological reasons caused by this medication that could have made her do this. So, that's an issue. If you're a man, this is often written off as just, oh, well, whatever, but I think this is a significant side effect to worry about if you're a man. If you're a man and you're taking aldactone or spironolactone, you can grow man breasts. It's called gynecomastia. And that's not comfortable if you're a guy. You probably don't want to walk around like that. So that's something to know about. Digoxin is a med that affects your heart rate. And what we really need to know about that one is you can be toxic even if your levels are normal. And that doesn't make any sense. How can you be toxic when your levels are normal? And it has to do with proteins and lower muscle mass and those kind of things. If someone is confused or irritable and they're taking digoxin, if they have an irregular pulse or heart palpitations, loss of appetite, nausea, vomiting, diarrhea, visual changes like blurred vision or blind spots or changes in how they perceive color, if they see halos or rings around objects or they're seeing lights or bright spots, that can be, not altogether, even just one of these can be a sign of digoxin toxicity. And I have a little picture here of that is related to Van Gogh. And we think this is a story in pharmacy because there was an herbal predilection at that time for taking around parties that had the active ingredient, had digitalis in it, the active ingredient in digoxin. We suspect that Van Gogh had some degree of toxicity, and that is why he painted things that way, because this is what he saw. So just a little historical FYI there. Blood pressure meds, obviously all those side effects could be contributed to aging, right? They could. But they're common and well-known side effects we need to revisit all the time. Just because you've been okay on a med for a while doesn't mean you're always okay on that med. So, psychotropic medications. Any medication that can affect the mind, the emotions, and the behavior. Some of them may also affect your body, so some mood stabilizers may affect how alert you are and how you think. Some anxiety medications may affect your short-term memory. So, for example, after my husband's parents died within close succession to each other, and he was the executor, and if you've been through that, it's a very stressful situation. So he was taking an anti-anxiety med for a short time during this, and would ask me every night, because the alarm clock's on his side, when do you want me to set the alarm? Because he gets up way earlier than I do. And for an entire week, I was late everywhere I went because he didn't set the alarm. He didn't remember that conversation. And from the minute we set it to when he was supposed to set the alarm to the next day, didn't remember it. Some meds used for tremor can lower blood pressure and heart rate, which could cause falls. Antipsychotics, I really want to hit these hard for psychotropics. They're popular. A lot of people are getting them. You may have seen the Abilify commercials. If your antidepressant isn't working, try Abilify. Well, Abilify is an antipsychotic. Risperidol is a common one. Seroquel, you've probably heard of that. Haldol, you've probably heard of that. People taking antipsychotic drugs are at risk for developing side effects known as extrapyramidal symptoms, and these are basically movement disorders. Before we go on with that, though, I also want to mention that antipsychotic meds also have that Benadryl effect. So you're getting that, and you're also getting, hey, I might have a permanent movement disorder. So what do I mean by movement disorders? I'm talking about lip smacking, blinking, grimacing, the undeniable urge to sort of be moving constantly. They may move their hands a lot. They may have symptoms that manifest that look like Parkinson's disease, and it actually may be just the medication. It may not be Parkinson's disease. So tremor, rigidity, slow moving, shuffling gait, hand movements. We used to call it pill rolling because that was like a common thing to call it. Now we're calling it air guitar. I guess that's a more topical way. It's not like air guitar. It's like air guitar, little tiny fingers. That's what that is. Chewing or rabbit nose movements, throat clearing or grunting, and anxiety-like symptoms. So if someone is maybe an older person and they're not as verbal as they used to be, we may see them pacing or foot tapping or rocking or shifting body from leg to leg, and we may think, oh, that's a symptom of anxiety. And then they might get an anxiety med. But really, we may have really needed to examine that antipsychotic medication instead. These movements can become permanent, meaning that you will be stuck with your neck to the side, making weird movements with nothing that you can do about it, which nobody wants that. It usually happens during long-term treatment, several years, sometimes months, but a lot of the times it can happen fairly quickly and, months, and persist after the medication stops. You may think, okay, well, we'll stop the medication, it'll fix it. No. That's not always the case. So really look for these symptoms if you're a caregiver on a continual basis for people who are on these meds, because if we catch it soon enough, it may not become permanent. Also, please note that there's something called neuroleptic malignant syndrome, NMS, which is actually a state that can become deadly. in people taking antipsychotic medications, most likely some other drugs, but usually antipsychotic medications. It's manifested by fever, rigidity, mental status, heart rate changes, blood pressure changes. You may even see like a fixed eye movement where it's rolled up. I was fortunate or unfortunate enough, depending on how you look at it, to be able to interview several patients that were long-term residents for psychosis, and I feel that they were reliable in telling me this. And I asked people who had a history of actually living through NMS, what did that feel like? It's painful. They all described it as unbelievably painful because you are rigid, and when you get the eye movement up there, you're fighting against it, and there's nothing you can do. So it's not pleasant. It's something to be on the alert for. Similar to that, there's something called serotonin syndrome. That's more associated with things like taking an antidepressant and maybe a migraine medicine, or an antidepressant and maybe an anti-nausea medication, or maybe an herbal like St. John's wort. We're going to kind of hit through this one pretty quick because it's fairly similar, but just different drugs tend to cause it. Maybe your Celexas, your Zolofts, Lexapro, those kind of things. Serotonin is good, but when you get too much, you get that serotonin syndrome, which is similar in the sense that you'll see rigidity, change in mental status, fever, sweating, GI symptoms in particular, because you have a ton of serotonin receptors in your gut. Large involuntary movements, which can manifest similar to stroke in some people, tremor, restlessness. And so basically we just try to stay away from having 2 or more antidepressants on the same person, and I'll tell you that is what happens all the time, always, because this one works a little different, so we want to add it in with this one. Try to stay away from that unless you have to, even if you're using them for 2 different reasons or they have slightly different mechanisms. Antidepressants and migraine medications, and like I mentioned, St. John's wort or anti-nausea medication, Zofran comes to mind for that. So combinations of medications can lead you down a bad path. I'd like to hit medication-related psychosis in Parkinson's disease, which isn't funny except for that the stories sometimes come out to be when the person comes through it and you tell them, hey, this is what happened with you. They're always astounded and they're, what happened? I did that? So you can get hallucinations on Parkinson's meds, delusions, paranoia, reckless behavior, poor impulse control, and psychosis. So just a list of meds there, your Mirapex, your Requip, Cinemet, Amantadine. There's lots of other ones that can do it. Tons of studies about this. But the stories are great. So there's a Canadian, and I have the link up there if you want to look this up. There's a Canadian online article recently posted, and I took 2 cases from it that they mentioned because I thought they were interesting. There was a 68-year-old man taking 2 Parkinson's meds. If you read the article, they'll tell you which ones. Daily for 6 months. Late one night, he got in his car and drove at speeds above 100 miles an hour on the road. I drive fast. Even I don't drive over 100 miles per hour. That's pretty dangerous. And after the incident, they did some interviewing with him. He expressed regret. He was confused. This isn't something he normally does. Case number 2 is a 69-year-old woman. So these aren't elderly people. I mean, this is, getting to older adult, but it's not, we're not talking about a 90-year-old person. Taking 1 Parkinson's med for 3 weeks. That's it. She was stuck in a line of slow-moving cars on a 2-lane road. She became so impatient that on a blind curve, she can't see anything else, but she just decides to pass this entire line of cars. And then afterwards, when interviewed, she reported feeling blank during the incident, and she was just very disturbed that she did that afterwards. There's lots of other cases, not in this article, that involve compulsive gambling, compulsive sex, compulsive shopping, and compulsive binge eating while on Parkinson's meds. And I just want to remind you, if you have any questions as we're going, I know I'm going fast, please go ahead and start submitting this, so we'll try to catch them at the end for you. And just to decrease that, if you know someone who's having those kind of issues, you basically try to reduce things that could be adding to the problem first. So Tagamet, it's an acid-reducing medication available over the counter, but it interacts with everything, raises the levels of tons of drugs. If you're on that, we're going to get rid of that. You may taper off some of your other Parkinson's meds that are meant to help, but they're not your main Parkinson's med. If we have to, we're going to lower your Parkinson's med dose, or we're going to change your Parkinson's med dose, and we're going to try to stay there as long as we possibly can. Sometimes, though, what's going to happen is somebody's going to prescribe an antipsychotic because you're demonstrating psychotic behavior. And so that's how they're going to try to fix it. It's not the best choice. It really isn't. But sometimes that's what happens. And that is known, as I mentioned, as a prescribing cascade. A prescribing cascade is prescribing one medication to fix the side effects of other medications. And as you know, the most common medical intervention we ask doctors to perform for us is to write a prescription. So we may be inadvertently, as a society, leading them down that road. There was a study that showed that people who were taking Reglan, which is a medication for gut issues, basically, were more likely to then get Sinemet, which is a Parkinson's disease, if they were taking Reglan at a later time. And this is a very well-powered study. And the reason why? Reglan for the gut disease, chemically, it's an antipsychotic. I'm going to go quickly through the first couple of slides. This is a Venn diagram, if you're familiar with those. But basically, the circles are issues, and where they overlap is where, whoa, we have a ton of issues. So just a visual representation. If you're taking a prescription drug all the time, and maybe an over-the-counter painkiller like Motrin all the time, and maybe an over-the-counter herbal medication to make you feel a little more lively, and then maybe you take a health supplement, these may be issues, where you can see in the middle where they overlap. So, and then here, it's the same diagram, but I've added on, hey, what if you take something just once in a while? Well, that's okay, right? It's just once in a while? Not really. That still interacts. Or maybe you're just taking an antibiotic for a week. Well, you don't have to worry about that, because it's just for a week, right? Now, look how that overlaps. That's significant. That's those drugs interacting with each other, and it's those drugs interacting with your body. That's a big deal. So to give you a concrete example, if you are taking Coumadin, which is a blood thinner, and a hypertension med like metoprolol, and an antidepressant. So you're just taking 3 all the time mainly. And you're taking your Motrin, because maybe you've got that osteoarthritis in the knees. And then maybe you're taking St. John's wort because you need more energy and you're still feeling depressed on the Zoloft. And then maybe you've been anemic in the past, so you decide to take some iron. And then your doctor says, hey, for a week, will you take this antibiotic called Cipro because you've got a urinary tract infection? All of those things interact. When I ran the interaction programs on this and did some extra research, it came up to 9 significant. There were many more interactions, but 9 significant interactions that could cause bleeding out from Coumadin or even clots because the Coumadin might not work well. The ibuprofen and that metoprolol, or ibuprofen and most of your hypertension meds, guess what? That Motrin's going to interact, and your hypertension med may not work as well. You may be at risk for that serotonin syndrome that I mentioned because of that Zoloft and that St. John's wort. Those 2 things interact. The iron, if you take that within about 2 hours of your Cipro, guess what? You're not going to absorb that Cipro quite as well as you should, and that urinary tract infection may stick around. If you had grapefruit for breakfast, guess what? Whew, that makes it even worse. Look at that. Grapefruit tends to, because it goes through the liver in the same way, raise concentrations of medications. So that can be an issue. Let's talk a little bit about over-the-counter medications, just briefly, just so you know, these things can interact. Calcium seems benign. Iron and acids, guess what? These interact with antibiotics, and such as Cipro or Levaquin or tetracycline or Avelox. If you have a seizure disorder and you're taking Dilantin, calcium combined with that, that's an issue. Acid reducers, your Zantacs, your Prilosec, your Prevaceds, your Tegamets, they can help you so that you do not absorb as much B12 as you need, as much iron as you need, as much calcium as you need. You might not absorb your Synthroid, which is a thyroid medication. And Tagamet, as I mentioned, raises levels of lots of other medications. And in particular, the one that's been in the press most recently, if you're taking Plavix because you've had a clot issue and you're taking Prilosec, you may be at increased risk for clot because those 2 medications interact, and it might decrease how well Plavix works. Now, Prilosec's available over the counter, so you'd figure it's super safe. You have to be aware. This is just a list of common herbals that I see, or supplements that I see people taking over the counter. And this is just a quick list of vitamins or minerals that people frequently take over the counter. All of the things on both of these lists have significant interactions with medications. And we don't have time to get through all of that, but I did want to mention a little bit about the risks of herbals. In the next few slides, I just want to be very clear. I'm not slandering anybody. I took this directly off. I cut and pasted it directly off the FDA website, which is listed up there at the top of your slide. I encourage all of you to go to this website. These are consumer alerts about herbal medications. The FDA sometime in the 90s was no longer responsible for ensuring that herbal medications and supplements are safe and effective. It is up to the manufacturer to determine that. They do not, the FDA does not, go in and check stuff out unless something bad happens or something gets reported. So I'm all for herbals and natural remedies, but what you have to realize is this opened the door for your snake oil salesmen. The people who are out there to make a buck because they're pretty sure that no one's going to check on stuff. They're out there and they're after your money, and that's all they want. So, just a quick background. I'm going to butcher the name of this Chinese medication. I'm sorry. I'm pronouncing it Keishe. Someone can correct me if they speak Chinese. Keishe is a slimming factor capsule and an all-natural blend of Chinese herbs. It actually says on there, an all-natural blend of Chinese herbs. Well, guess what? The FDA was called in for whatever reason to investigate it, and this is what they found. Not all-natural Chinese herbs. Fenfluramine, taken off the market in 1997 because it causes serious heart valve damage. Propranolol, a prescription beta blocker medication that can cause problems in people who aren't supposed to take it. Sibutramine, recently in the press in the last 5 or 6 years about increased risk of heart attack and stroke, and it's a controlled substance. Ephedrine, it's a stimulant that's legally marketed, but it can pose a risk if you have cardiovascular conditions. That's not all natural, baby. That's dangerous. So be aware. These people are out to take your money, and that's what they're there for. Not all of them, but some of them. So you have to be aware. I want to talk about fitness waters. I've got someone in the audience here who's holding a fitness water, so that made me extra excited to talk about it. And herbal supplements. So I'm putting these two topics together, just so you know. I had a sinus issue about 5 weeks ago, and I was taking some over-the-counter Sudafed because it just was causing me all sorts of issues. So I'm just going to preface this story with that. And I was drinking a bunch of fitness waters, like maybe your vitamins, your vitamin waters, your Sobeys, those kind of things. And I thought, great. I had the worst week of insomnia in my entire life. I felt weird, and I couldn't function, and I was drinking all different kinds. So finally I decided to look at the label because I was really only looking at the calorie content before then. Guess what? They contain guarana, which is huge on caffeine, ginseng, ginger, green tea, dandelion root extract, and the next 2 slides will just tell you a little bit about what these things cause, and I'll flip through them pretty quick, and I'm happy to send you any information you want to know about these. But especially with the pseudoephedrine and me, it could have caused a potentially fatal irregular heartbeat. And I was feeling some palpitations that week. I couldn't figure out what it was. I want to let you know that because these are foods and they are under the FDA, the reason why they're allowed to put this in these waters and in supplements is because it's under something called GRAS, generally recognized as safe, meaning that, hey, we think it's safe. I'm going to tell you as a pharmacist, I do not think it's safe. I think it interacts, and I think it's a problem. So there's list after list after list after list there you can see. I want to mention the dandelion root extract, by the way. It seems, dandelion. Oh, it's herbal. It's nice. You know what? It basically acts like a potassium-sparing diuretic. It can elevate your potassium dangerously, especially if you're already on a potassium-sparing diuretic, or if you're taking Yaz, which is a birth control that raises potassium. Quick tips. And this will wrap it up, and we're happy to take some questions. Actually, I have some questions I'm excited to answer here. I want you guys, anyone, but especially older adults, keep a medication list. Update your medication list, and take that list to all doctors, including herbals, your OTCs, things you only take once in a while. It's so, so important to let your doctor know what's going on with you. And your pharmacist, we want to know. Sometimes your pharmacist may seem really busy, but they need to know. If you don't take your medications as directed, for example, I always get I only take my blood pressure med when I have a headache. Please, please tell your doctor that. They may just keep increasing your dose, and that's not really what needs to happen in that situation. Use one pharmacy. If you can get away with it, just one. Sometimes you can't, but this will help us figure out what's going on with you better as pharmacists, and we can really check those interactions. When you come to me and you tell me at the pharmacy, hey, I'm taking this, this, and this, and it's not something that I'm dispensing to you, it doesn't stay in my database, so please keep reminding me and other pharmacists. Ask your pharmacist about interactions, of course, and if that pharmacist is not helpful, ask a different one. Go to events like Brown Bags where you get to take your medications and talk about your meds. Question your doctor before they give you the med, while you're taking the med, and after, even if you've been taking it for a long time and you're starting to have side effects. It's important to revisit repeatedly your medication list as cause for problems because your body is changing as you age. It's not stagnant. It says MD here. Doctors sometimes don't get a lot of geriatric education. I really meant to say healthcare professionals don't get a lot of geriatric education. I had to seek mine out. Doctors usually have to seek theirs out. You have to do special training to get what you need to know about the geriatrics, and it's complicated. Just so you know, doctors get a great overview of pharmacology, but they don't get a lot of in-depth pharmacology. Each medical professional has a certain specialty and a framework of knowledge. Please revisit everything with everyone. Get knowledge from different sources and go back and talk with your doctor. Doctors are people pleasers, and we are a pill-popping panacea culture, meaning that we want a pill to cure everything. There's studies that show that doctors are rated as, better doctors if they give you a prescription at each visit. Try not to pressure them to give you a pill unless they want to give you a pill. And then nurse practitioners, they're clinically observant. You've got to ask their opinion on stuff. Creating optimal drug regimens that meet the complex needs of elderly people requires thought and careful planning, and these multiple conditions with multiple meds is even more complex. We really need to go through everything over and over again. Your med list isn't stagnant, your body is not stagnant. And remember that almost 30% of hospital admissions in the United States are for elderly people who have medication-related issues. And the last slide, I want to remind you, older people, older adults deserve respect and consideration for the following things: their feelings about medications, the complexity of their medications, and the complexity of their disease states, and the complexity of their financial situation with regard to medications. It's very important. Cost is important. Experiencing of medication side effects. You always get the, that happens in less than 1%. Guess what? The elderly are the less than 1%, so take it seriously. And their desired quality of life. If they want to go golfing, they want to play with their kids, they want to go out and, hang glide. If that's what they want to do and their medications are impairing, what we need to do is really assess what's going on with them. So at this point, we will go over questions, and if someone could direct me, should I read these? Okay, I'm going to start with this. I like this one. My problem is just the opposite. My mother is reluctant to take her meds and more often than not refuses. Your mother and my mother may know each other. That's how my mother is. I don't think she has dementia, okay? I think it's just part of her way of thinking about medicine, and do I have any recommendations? In that case, and I'm going to tell you right now, I used to work with a very unscrupulous pharmacist when we worked hospital clinical care together, and she would trick people. She would lie and say, oh, it's a vitamin, and give them something else, which is unethical and illegal. So we don't want to do that. Respect what she's saying about the medications. See if we can do something with education. Maybe a geriatric specialist pharmacist or a regular pharmacist can talk with her about at least getting her to maybe take some of the more crucial ones, and go to the doctor and say, hey, she's reluctant to take it. She doesn't want to take this many. Can we pare it down to anything that we think we can get her to take? Continually talk with her. It's an education thing. But people do have the right to refuse their medications, and it's a fine line. Prescriptions are so expensive. I've thought about going across the border to buy my medications. Some people have told me it's unsafe, but if it's the same medication made by the same company, why wouldn't I do it and save a lot of money? I used to live in Tucson, Arizona, which is about an hour and a half from the border. And I will tell you, I have done this myself. And I'm not allergic to penicillin, but boy, did I get a rash from that penicillin. And let me tell you what happens. In the United States, if something doesn't meet our FDA rules, a lot of times it gets shipped out to other countries who have different rules. A lot of times it sits in a corner with rat feces and cockroaches and then gets repackaged and sent to different countries, such as Mexico. Maybe sometimes it's just got shuttled off or siphoned off a truck. There's tons of drug stealing out there. Let me tell you, FDA website, you will be enlightened. And guess what? It ends up in Mexico. They may repackage it. It may sit there. It may melt, and then they re-stick it together. It's not the same medication. It probably is not. I'm sorry. So really, if you can possibly help it, I wouldn't do that. When I was in acute care hospital, I had a lady with complications that could never eat solid food again, related to doing medical procedures and taking medications in Mexico. Next question. What would you consider to be the most dangerous of herbals or supplements? Okay, I'm going to give you an answer that's going to sound like I'm joking, but I'm not. I'm so not joking. Herbals or supplements, by and large, that start with the letter G tend to be, for whatever reason, the ones that we really see interact with medications. So your ginkgo, your ginger to some degree, your ginseng, those kind of, your green tea. Those kind of things really, really interact. And a lot of it is because they're stimulant in nature, some of them, but a lot of it is because there's different versions of them. So since they're not regulated by the FDA, oh, you know what, I can't get this batch of stuff that we wanted to use for this, we're going to use this batch. Well, guess what, that batch doesn't work the same as this other batch. And the dosing actually isn't regulated by the FDA. So you could get a pill that's supposed to have 5 micrograms of something in it, but guess what, it has 75. So that's something to think about there too. But really the things that begin with G, these are the things that we worry about the most, or anything that falls into something that's like a diet aid or a stimulant. I really worry about those causing acute effects. Garlic, I want to mention garlic, bleeding complications if you're on Coumadin. Another G. How does Tylenol hurt the liver? I think I went over this a little bit, but I really want to draw you a big pharmacology chart, and I can't. So I'm going to say this again just really quick. Basically what happens is, it's all hunky-dory when we're going down the normal path of liver metabolism. You take in your Tylenol, goes through the blood, goes through the liver, because almost everything goes to the liver first. It's called first pass. And gets broken down fine. But sometimes if you're drinking alcohol, you have liver problems, you're taking other medications, it builds up so much that that first pathway gets overwhelmed. You switch to the second pathway. That second pathway makes toxic substances. These toxic substances are poisons. Your body has actually made a poison in converting this drug, and it kills the cells in the liver. And then your liver stops working, and that is what happens with liver failure. Your liver helps process everything in your blood, and so that's why it can cause death. I hope that was a satisfactory answer to that one. Psychotropic drugs, can you explain more about irreversible side effects? Really, when we're thinking about the psychotropic drugs and the irreversible side effects, it's mainly the movement disorders that we're thinking of. And usually, and I can try to get some good references on this, but usually what they say is that when you start seeing people with the lip movements and starting with the finger movements, that's where it's probably first manifesting, and that's where we need to intervene before it becomes permanent. Because what happens is it's not just that it's a movement disorder, right, where I'm now cocked to the side and I'm leaning over and I'm twitching like this all the time and making lip smacking. It's not just that that's sort of unsightly and that that's uncomfortable and that's embarrassing. It's that now my chest is constricted and I'm not breathing as well. It's that I can't move as well to do what I need to do. And then I get depressed, and then things happen, and it can lead early on to death. And people who are actually on antipsychotics, perhaps they're having psychosis forever because they have a mental disorder, they used to die. They still die earlier, but they used to die much earlier, mainly due to these irreversible side effects. So it's mainly movement related, and then eventually the inability to move related. Is the pharmacist more qualified to review medications than an MD? I don't think more qualified. I think we have more pharmacology. So what happens is that your doctor, and doctors are great. I'm not going bad on doctors at all like this. It's just that, as you know, the medical field is specialized. Older doctors used to do everything. Older nurses used to do everything. They used to dispense meds. And now we're all getting much more specialized. So what happens is that you're less knowledgeable about certain areas to a really in-depth degree. So if there's somebody who's maybe having a rare side effect, pharmacist probably is just going to have more time, more access to databases, more experience in the area of, hey, could this really be caused by a medication? And then we coordinate with the doctor to see what the doctor wants to do about it. So because the doctor's driving the bus, that's what's going on. And the doctor should be driving the bus. Let me tell you, I don't want to be diagnosing or doing anything like that. That's out of my scope and not something I ever wanted to do. But what I do want to do is act as a resource. I've always thought of myself as a medication librarian, really. So I'm here to serve as a resource to help people out. Oh, lower. Can I just hold it down here? Okay. So, and then how do I find a pharmacist that specializes in geriatrics? There's a geriatrics website, and you can go to, I think if you just Google geriatrics and medications, there's a list. It's a CGP, so Certified Geriatric Pharmacist, CGP website that has a list of geriatric pharmacists on it, and I'm on it, and other people are on it, and I think it has our contact information because I've had people call So, and you know, your regular pharmacist may either know someone or be able to help you out with stuff like that. Sometimes they can't help you out during prime time, you know, right after work when everybody's picking up their meds and the sick kids are there. Give them a list and say, hey, you know, I'd really appreciate it if you could go through this. So, and I think most pharmacists are happy to do that. If you have a pharmacist who's not happy to do that, I'm just going to say this as a professional, you're not a very good pharmacist. So, we're here to help people. That's what we should be doing. Is it ever okay to take outdated drugs? I like this question. I'm going to give you kind of a sketchy answer. There was a flu epidemic, and we were all taking something called Tamiflu when we needed it. And at that time, the FDA said, hey, you know what? It's okay to use outdated Tamiflu in this situation. It's really only okay if they say it's okay in certain situations. And I'll give you an example. Some Parkinson's medications actually break down over long periods of time into toxic substances. Some medications become less effective, some become more effective. And I think, you know, we've all got the common sense to say, okay, you know, if it's a day past the expiration date, I really shouldn't take it, but we wonder, you know, really will it be okay? You have to follow the FDA rules on that and really try not to take those outdated drugs. I've seen people with drugs they bring in from like 2002, and I can tell by looking at them, because I'm used to looking at pills, ooh, these changed color, you shouldn't be taking these. Oh yeah, they change, it's funny. Because, you know, you have to think they're meant to dissolve in your body, so when environmental conditions come into play over years, they can break down just sitting right there. So, how do you best approach speaking to families about medication concerns as a healthcare provider? You know, I think it's best to approach them, in my experience, by asking them the first question, such as, how do you feel about medications? How do you feel about how your loved one, if we're talking about someone we're caring for, their diagnoses? Do you feel that they're accurate and you're okay with those? And how do you feel that she's acting, or he or she is acting on the medications that they're on? I usually start there, gather information about socially how these people feel about medications. Everybody has, you know, their own individual feelings about medications, and some medications in general. My dog just got put on theophylline. I don't like theophylline. I don't think it's a great drug, but it's working for my dog, so I'm using it. It seems guarana and taurine affect meds a lot. Ooh! You have been doing your research, whoever wrote this. Yes, I do. Especially taurine. And taurine, if you are one of those rock star drinkers or whatever, and you're drinking it at the bar with the drinks, taurine isn't well absorbed unless you're taking alcohol. That's when the real side effects occur. So you all need to be careful with that. How does coffee affect meds at all? Coffee actually can affect medication metabolism, but not as much as you might think, because there's two different enzymes. Well, not two. There's several different enzyme systems. But the enzyme system that coffee goes through, most meds don't really go through that to a significant degree where it's going to cause that much of an issue, unless you're taking so much caffeine. That's the problem. Or, incidentally, if you are Asian, lots of Asian people have a difference in how they metabolize caffeine, and then it will build up longer in the body, and you may experience, like if you took a cold medicine, more significant side effects than someone else would, interaction-wise. And is there a limit to the number of prescriptions a doctor can give a resident? There is not. There is something called, 9+ meds that we all started thinking about for several reasons. There's actually a lot of reasons why we all started thinking about 9+ meds. And that's actually starting to fall by the wayside, and that's good. Really, I want you to start thinking about interactions when you start getting 3 or more meds, including over-the-counters. 4 or more meds in the elderly has been statistically shown to increase fall risk. But there is no limit to the amount of medications a doctor can prescribe. If you have someone with lots of terrible conditions, not terrible, but a lot of serious conditions going on, the actual recommendations, let's say from the chest guidelines or from the asthma and COPD guidelines, recommend multiple meds because they work mechanistically different. So we end up back and forth. The doctor's doing what they're supposed to do, but now we have all these side effects and we have all these meds. And that's why I say we have to revisit all the time. Continually go back. And that's all for questions? Excellent. Well, thank you so much. I'm so excited to talk about it. I apologize. I talk super fast. I'm originally from Iowa. We're fast talkers up there.